Well,
Yes, yes.
okay. So I didn't really have time to prepare anything, but I guess I can just share with you my experience the last 24 hours. So I worked at Ahli Hospital for 3 weeks. It was a really challenging 3 weeks. At the beginning, it was actually still during the ceasefire, but there truly wasn't a ceasefire. We were getting injuries from quadcopters and explosions daily. Areas that were not technically considered the red zones or the border areas, areas that may be close to it, multiple children that, one particular kid was just filling water, and a quadcopter dropped a bomb and he was killed along with 2 other people. And then on March 18th, the war started again, and it was just one mass casualty after another. We would take care of patients just on the floor in the courtyard. It was so chaotic that sometimes like patients would go almost unnoticed. Like there's no way to keep track of who's been seen and who hasn't. It's just pure chaos. You're walking over bodies just to get from one patient to the next. So I was there for 3 weeks, and then I worked at Nasser, and I'm at Aqsa now. And I've actually been trying to go back to the north, just because the need there is so desperate. I mean, the Al Ahli Hospital, it's a very small hospital that was not meant to serve large populations, and it's been serving as the main hospital for these horrible attacks. It's the central hospital, it's the hospital with the CT scanner. And despite all of that, I mean, it's so limited, and we were working in an emergency department without a single ventilator. There's no central oxygen supply. We're using these huge tanks of oxygen. I needed to intubate a child, a 6-month-old, and I didn't have an appropriately sized ET tube. We didn't have a appropriately sized IO, just so limited, yet it was the best there. It was doing the most. And the areas that are being attacked are very close to the hospital. So with every explosion, I mean, it was so close. It almost feels like every explosion is right there in the courtyard of the hospital. We knew we would get the cases. So I've been trying really hard to go back, just because I really felt like I needed to go back and support my colleagues that were there. We were supposed to go on Saturday. There was a scheduled rotation to the north, and then it was canceled, and with the plans to go on Monday. And then last night we were working here. We had a mass casualty, not very many patients, but actually a tent on the hospital grounds was hit at Aqsa Hospital. And so we were taking care of patients. And then I actually got a phone call from one of my colleagues at Al Ahli telling me they're forcing us to evacuate, and my heart dropped. Like I've never felt so much fear for people that I know, because I knew what that meant. So everyone just left. They ran for their lives, and I'm sure you guys saw the videos of patients, being carried by their family members trying to carry the beds in the streets to get everyone out. And then less than 20 minutes, they bombed the hospital, and they bombed the main building that was struck was the building that the ambulances park next to, and it's where the paramedics rest, and it's right in the center. So that explosion impacted the buildings behind it, which is the lab and the pharmacy. And then right next to it is the emergency department. So the emergency department, the entire side wall was blown out, and the oxygen tanks all exploded. So the majority of the damage and destruction was to the ER, and it's completely out of service now. It's there's no way that can be reestablished anytime soon to serve patients. The surgical building is still intact, and there are still patients there. They were not able to evacuate all the patients, but thankfully those patients are okay. But there was no staff to take care of them. Everyone left. I think only 3 nurses And actually one American doctor stayed, and they did what they could to care for these patients. And a lot of the patients were patients that were suffering injuries from an earlier explosion just that day. So they were still in their like acute critical phase. So, you know, they just tried to kind of do what they could. And then once things calmed down, ambulances came and they started to evacuate the patients out. I've heard of confirmed 3, but I'm sure more than that patients that died on their way, just trying to make it to another hospital. I mean, they're in the street. Like some patients, their family members carried them to either a Khidma al-Amma or a Shifa, but 3 patients, when they made it to Khidma al-Amma, they were dead. One of them was a young boy they had injuries from earlier in the day. He had a traumatic brain injury and he was supposed to be on oxygen, and unfortunately he died. You know, you come here and you form these connections, and I swear they're like family to me. So when I heard the news, it was terrifying, because I didn't know if the amazing, beautiful souls that I met and I spent every day with for 3 weeks straight, you know, you go through so many emotions with them: fear, tragedy, loss, you know, love. It was Ramadan. We prayed together, we broke our fast together. You know, despite everything, there were so many beautiful moments. And in that one moment, I was like, they could all die. And it was horrific. It was terrifying. And now just seeing the images of the hospital, and, you know, just who knows where they go from here. And now they're going to try to route all the patients to the few other remaining hospitals that have also been attacked, that are barely functioning. And who knows if they'll get targeted next. It's a really scary thing to think that, you know, these hospitals are, and Mamadani's been hit multiple times. It's been evacuated multiple times. The nurses that I'm very close to shared stories with me of when the hospital was surrounded by tanks and they had to go through questioning, and how they had guns pointed at their heads, and they didn't know if they would make it. And they're so committed. Some of them, one of the nurses was 23 years old. She's 23 years old, and she was away from her family for over a year, every day sleeping at the hospital, taking care of patients, not knowing if, you know, she would be, imprisoned, or if she would be killed. And they're just so committed, to the point where even after they evacuated, they were on their way to Khidma al-Amma, and then they went back to the hospital. They went back just maybe 20 minutes after it was bombed. They were like, we have to go check on the patients. We have to go check on the patients. And I was so worried for them. I was like, wait a little bit, because they issued another evacuation, but they're just so committed to their patients, and they're so committed to their people. And they're there now. They're staying there because they want to at least be able to provide some support to the patients that are still there until they can transfer them out. They're, I mean, mashallah, like the strongest people I've ever met. They're amazing. They're truly heroes. Us, you know, we come here, we volunteer, we're here temporarily. We know that we will ultimately leave. But they're the ones that have been committed every single day, every single minute since this war started. And they have not given up, and they haven't, they could easily just be like, I'm done. I'm not working. I'm not going to work. I'm just going to stay with my family. But no, they show up and they stay and they don't leave. And I just pray that they stay safe, and that hopefully this all ends soon, because it feels like a really, really horrible nightmare. I couldn't sleep, and today I just feel like everything that happened yesterday was just a nightmare. It feels so unreal to see the images of this place that I was just at a few weeks ago, completely destroyed. I'm sorry, I feel like I was just rambling, but it's been a lot.
You don't need to be sorry.
Iman, can you hear me, Iman? I don't think. I have a question for you.
Yes.
Razan, Iman, since you know you're a journalist, and do you have any journalist questions for Razan since she's here since she's with us here?
I'm not a journalist. I'm a former journalist. And what I
Okay.
would say is the most important thing for Razan's statement is that we immediately put together a press release and send it out to every single agency. And because this is an emergency. I mean, it has been an emergency, but at this point, what Razan is saying is that we don't know what's going to happen to those people at Al Ahli. And we need to put out a press release as soon as possible to every single network and make these doctors available to speak about the situation. Either doctors here who have worked at Al Ahli or doctors there. But this is the number one most important thing because according to what Razan is saying right now,
Yeah.
and I do have a couple of questions, Razan. According to what you're saying, we don't know what's going to happen to all these patients. Most of them are now in the street. Some of them you said have died. You know,
So as of last night, there were patients that were in the streets. I would assume that by now, most of the patients have either succumbed to their injuries or they've made it to either one of the other hospitals. These are the ones that were attempting to evacuate. There are patients that are still at Al Ahli right now, and I just got off the phone with one of the nurses that returned, and she said that, you know, they're able to provide them with as much care as possible. The operating room is non-functional, so if they require surgery, they won't have surgery, but there are ambulances that are transporting patients to both Shifa now and Al Khidma Al Amma. But you know, at some point, the question is going to be, are they going to completely evacuate that building? And it has an ICU and it has a surgical ward. Are they going to evacuate that entire building? Or are they going to just continue to maintain those patients there until they can either be discharged or, you know, transferred to another hospital if they need other care? Nothing is clear right now, honestly. Khidma Amma, Ahli has a CT scanner. It's currently the only hospital in the area that is operating a CT scanner for patients. So even today, patients were sent there for CTs from Shifa, which is kind of what the process had been. Even they would send them there from Indonesian hospital for CTs. So it can't just be shut down entirely because there's a service that is very necessary that is being provided there. I heard that there's another private hospital that has a CT scanner that they're trying to sort out, you know, if it's closer to Shifa, if it can be used instead. It's like only 2 minutes away. But that's still something that I think they're kind of looking into because it's a private hospital. But you know, even the staff, I mean, all the staff that work at Ahli, just this transition period of redelegating everyone and figuring out like which hospital are you going to work at? Is there, you know, there's going to be a lot of patients, but then you're still stuck with the same issue of very limited space, very limited beds, very limited resources. So I think the next couple of days are just going to be a matter of just figuring out how to move forward. I think that I think some of like the administration, I think they may have done like a survey of Indonesian hospital today just to kind of figure out what to do next as far as trauma cases go. We're still supposed to go to the north tomorrow. Unless it gets canceled again. It'll be the third cancellation. But for now, I think the plan will be to go to Al Shifa and just support there.
Razan, I have a question for you. What is the explanation for evacuating the hospital and attacking it? What is the justification for that is given by the Israeli forces? What happens? Like, do you know how the order was
So-
given and the justification for it?
So evacuation happens in a number, and I'm not a professional or an expert on this, but from being here and asking questions and understanding kind of how the evacuation happens for different areas. Some areas are evacuated via social media, Facebook. Some areas get the pamphlets. Some people get phone calls. They literally get a phone call, hey, the building next to you is gonna get bombed. You need to evacuate and tell your neighbors to evacuate. So it really just depends. Yesterday, someone got a phone call. Someone got a phone call because it wasn't in the news, right? It wasn't released on Facebook. There was no map. Someone got a phone call, and then very, very quickly, they went around just telling everyone in the hospital, you have to leave, you have to leave, you have to leave. And within seconds, people were running to leave. And they know, because it's not like, oh, you have to evacuate and something's gonna happen in a few hours. They know it happens within minutes. And that's like the terrifying thing. Because you could still be close enough to be impacted by whatever shrapnel flies your way. So someone got a phone call and they evacuated. So from the explosion itself, there were no major injuries, just like very minor injuries, nothing major, because people they were able to get away quickly enough from where the hit was. But I mean, who can say why Israel gives an evacuation notice before they bomb a hospital? Who can say? I mean, why do they give an evacuation sometimes and other times they bomb without giving evacuation? It's arbitrary. I mean, it's sick is what it is. And I think it's strategic in a sense because they know that this hospital is caring for the majority of the population in Gaza right now, because after the ceasefire, so many people returned to the north, and despite the war returning, they are staying put. Most people have not come back to the south. They're staying put. They don't want to leave their homes. They don't want to leave their land. They don't want to leave their place. And so this hospital is caring for the majority of patients. Now you wipe out that hospital, you've wiped out their lifeline. You've wiped out their lifeline. And it's not just, it's not just traumatic cases. I mean, there's so many medical cases. All of these patients, they still have a lot of medical conditions. Every day we're seeing so many patients in heart failure, so many patients in DKA. And this is where they would go. And now this huge lifeline has been completely cut off for them.
So
They're just
Razan,
squeeze them, suffocate them.
Razan, if you don't mind me
Oh.
asking, so we're talking about a hospital. Do you have any estimate, like in your mind, how many patients were in that hospital when it got bombed or before it got bombed? And knowing that this hospital is the only remaining functional hospital in the north, do you have like a few hundred patients there who mostly are in critical condition from injuries or critical chronic conditions? Any idea and suggestions how many people were there?
Let's say I don't have the number. I want to say hundreds of patients. I maybe 300 maybe, but I don't quote me on that number because I could be way off as far as how many patients are there. But it was very, very busy to the point where there were no beds for patients. I mean, just in the time that I was there was 3 ICU beds. Okay. There was a child who fell from the 4th floor. The entire building, this was pre the ceasefire collapsing, he was just looking out the window, and because the foundation of the building is so weak now after it's been struck so many times, it just collapsed. And he had severe pulmonary contusions. I intubated him in the ER. He went to the ICU. The next day, they needed an ICU bed for a patient. There were no beds. So what did they do? They were like, oh, he's doing a little better. Let's extubate him. He was extubated. He went to the floor. The next day, he's in respiratory distress again. He went back to they got another patient out to put him back in the ICU, re-intubated. Then same thing the next day, I literally went and I begged. I was like, please don't let this child be the one that you take out because he's gonna decline again. And it happened again. He went in and out of the ICU 3 times because another patient will come and they they need to be intubated, then they need an ICU bed, and there's no ICU beds anywhere. So they look and they're like, okay, this patient still needs ICU, but they're the least sick. They're the least critical right now. Let's see what we can do. Maybe they'll do okay off the vent. And it's horrible. And I mean, I don't blame them for having to make those decisions, but it's puts the patients in such a horrible situation. And the same on the floors, the patients are stacked right next to each other. I mean, it's so condensed, it's so packed. So I can get the number for you as far as how many patients were there at the time of the explosion.
Yeah, thank you. So do you think,
I
in your mind as a doctor, do you think there should ever be a justification to just immediately evacuate a hospital? Is there ever, as a doctor, as a person who cares about life, about protecting life, is there anything in this world that should ever or can ever justify immediately evacuating a hospital or bombing a hospital?
There's no justification ever in any situation for attacking a hospital, ever. It doesn't matter what they say, who they believe is in the hospital, what they think is happening. It does not matter. This is a hospital with innocent civilians that have been injured in this horrible, horrible war that they have no control over, no say in. And yet they're the victims, and then they've already been injured, they're already suffering, and now they have to either evacuate or get killed in an explosion in the place that's supposed to protect them and keep them safe. There's absolutely no excuse and there's no justification. And mind you, the majority of patients that I saw at Ahli were children, babies, the actual babies, like 6 months old, 8 months old, a year old, 2 years old, babies. And then young children, and they would come in swarms, 5, 6, 7 children. It was the majority children, and then women, and then some men. But they take down an entire building, and it's all young families with multiple children, and there's no justification for that at all.
Thank you, Dr. Razan, for confirming this. Yes, there should never be an excuse, whether false or even if it's true, to bomb or evacuate a hospital. This should never be allowed anywhere in the world. And this is protected and covered by all international laws. And even if the international law does not cover all the details, even if there are loopholes in international law, the international law should be, fixed. It should be corrected that hospitals, uh, places where people go to get care to save lives should never be a target under any excuse, whether it's a false, a fabricated, or even if it is true. We as healthcare community declare and announce that hospitals, healthcare workers, patients, even if they are militants receiving care in the hospital, should never be a target. This must be the rule of the land everywhere in the world. And we, of course, we know all the Israeli accusations are false, are fabricated. They never proved their accusations. They never came with an evidence about the 36 hospital that they have bombed and attacked many times over and over again. One last thing, sorry, Dr. Razan, one last question for you. You are an American doctor. You work in major American hospitals and institutions. If you are in the United States and you work in a hospital that has 300, 500 beds, and for some reason the administration decided they want to build a new hospital, they want to move the patients there. In your opinion, how long does it take to evacuate 500 or 300 patients from a facility to a nearby facility that's fully functional, let alone throwing them in the streets? Like, do you have any estimate? Like, if you are in the United States now, would it take weeks? Would it take a month or two? How many ambulances do you need to evacuate all these patients? How many ventilators you need to evacuate these patients or transport them from a hospital to another? I remember working in the ER, many hospitals here, just transferring a patient from one hospital to another, maybe because they have more intervention stuff like that. It takes us a whole day. The process of just transferring one patient, having all the equipment, all the ambulances, all the teams available. It takes a whole day to transport one patient. So expecting a whole hospital that's already in terrible shape, that's already overwhelmed, that's already have patients on the floors and stuff like that, to immediately, whether within 10, 20 minutes, to evacuate everyone else? You know, how reasonable or how crazy you think this situation is?
There is no reason or logic. They could care less if the patients were evacuated or not. They could care less. I mean, these patients, they were people who were attacked in their own homes, in their own tents to begin with. And they know that it's going to be impossible to evacuate the hospital. They know that there are patients who are critically ill, who are requiring, whether it's oxygen support or pressors or whatever it may be. The moment these patients exit the hospital, their mortality risk increases significantly. They're on the streets. They're not in ambulances. They're not on stretchers. They're not attached to monitors. Even the ambulances themselves are not equipped to transport these critically ill patients. These ambulances, don't imagine an ambulance in the United States. It is bare bones. It is a one cot and then a bench that most of the time each ambulance will house 3, 4, 5 patients, and each patient with a family member. So they're not equipped, there's no monitors. If you're lucky, maybe you'll have an oxygen tank if the patient's requiring oxygen or is intubated. But their intention is not to, oh, let's get these patients out safely. Absolutely not. They could care less. Honestly, it feels like a joke, like, oh, you gave them 18 minutes to evacuate a hospital with critically ill patients. I mean, I don't know. I think I'm like kind of still in a state of shock. But like there's like an error, like my brain cannot comprehend it because it literally does not make sense.
Razan, one question. There has been no aid coming to Gaza for over 2 months now, almost. How, you have been in Gaza since the ceasefire. Can you tell us how are people getting food? How is the hospital getting food or medications or supplies? What is the situation on the ground?
So the hospitals, during the ceasefire, the hospitals and people in general, people who can afford it, I think they had a feeling that the ceasefire wouldn't hold. So a lot of people stockpiled. So the people who are able to afford it and are able to stockpile are doing okay. They have some supplies. The hospitals also have some supplies, but they're not endless. And even during the ceasefire, what was getting in is not what was necessary. So the things that are lacking are the same things that were lacking pre-ceasefire. Limited medications, limited, instruments, tools, even limited suture, limited stock of gloves. I literally have to beg to the stock people to give me a box of gloves because they're trying to ration it because they know they're going to run out. They have to ration it. So it's one box of gloves at a time that gets distributed to a huge ER. So one of the biggest issues right now is no diesel is getting in. There's no fuel. And the hospitals run on diesel for the generators. So Aqsa Hospital, for example, has one generator right now and a backup generator. This generator has been running for the entire duration of the war. If this generator breaks, this hospital is going to be non-functional. On top of that, they have a limited amount of diesel. Probably, I tried to get an estimate of how long they think it would last a few days ago. They told me 10 days. In 10 days, if fuel doesn't get in, there will not be any more diesel to run the generator. And that's the same situation for all the hospitals. So there's going to come a point where hospitals will end up having to shut down if fuel does not get in. As far as food in general, there's still some food distribution that happens among the tents. And even at the hospital, they distribute like rice every day, most of the time, to the staff. But the supply is becoming less. It's very difficult to find bread. Everything is incredibly expensive when you try to buy it. Most people don't have money. So there's a very obvious lack of food, a very obvious lack of resources. People are going to go hungry very soon.
Razan, I have a very specific question for you. Do you have the medications that you need to run a code in the hospital? Let's say, somebody coded. Do you have, the epinephrine, dopamine, Versed, things for seizures? Just, give us an idea as if we're with you.
Yeah, so we have epi, we have imiodarone. We don't have like the second line medications, like we don't have procainamide, for example. We have adenosine. We have some sedation meds, not all, but everything is in limited quantities. And that's what we have to remember. So I wanted to give a patient Keppra a couple of days ago, and I was told there was no Keppra. So I specifically wanted to give this patient Keppra. So I went to the pharmacy, I asked, she went to the pharmacy upstairs, found me one vial of Keppra, one. Yesterday we had a patient with a snake bite. He needed antivenom. We found 2 vials of antivenom. If you know anything about snake bites, usually they need 4 to 6 vials, if not more. Thankfully, I think it was just like a minor bite. I don't think he actually, there was any like venom. I don't think the snake actually bit him, but he was lucky because if he had, we would not have had enough antivenom. When it comes to, we don't have beta blockers. I mean, we don't have metoprolol. We don't have IV metoprolol to give patients or diltiazem. So AFib patients, you DIG, that's the only thing we have available.
For people
What
who are
else?
not medical, Razan. So metoprolol is like ABC medicine. Like if any hospital is like it's for the blood pressure, for heart failure, for anxiety, for everything. It's like something every hospital, every healthcare worker uses like candy because you need it. This is a basic medicine that you need everything. So something as basic as metoprolol is not available. This is shocking. So beyond the anesthesia,
No IV labetalol, no IV metoprolol. Most patients, if they come in hypertensive urgency or emergency, they'll get like captopril, which is like I don't know what line medication that is, but it's definitely not first or second line. Even for, I think we don't have for strokes. I mean, I've seen so many acute CVAs that in any scenario would have gotten a thrombolytic. We don't have thrombolytics. We can't treat strokes. So you diagnose the stroke and you rule out a hemorrhagic CVA, and then you're like, okay, well, here's some aspirin and Lipitor, and sorry, antibiotics, everybody gets Rocephin. Everybody gets Rocephin. When they go to the floor, maybe they'll get Vanco, maybe they'll get meropenem, but other than that, limited supply of antibiotics. And there's so much antibiotic resistance. So most of the time you're giving antibiotics. I saw a patient had a urine culture and it was literally resistant to almost everything, even meropenem. And mind you, these patients, I see them in the ER, but sometimes I'll follow up in the ICU to see how they're doing. They all develop secondary infections. Every single patient develops an infection. So many patients get intubated, extubated, re-intubated, extubated, re-intubated, ARDS, ventilator-associated pneumonia. The tubing on the vents, the tubing that they use, that's supposed to be disposable. Those have not been switched out since the beginning of the war.
Wow.
It's the same tubing that every patient is on because that's all they have. On the ventilators, there's the attachment to humidify the oxygen. None of the ventilators have that. So it puts the patients at higher risk for ARDS, for ventilator-associated pneumonia. The other day we had to intubate a patient in status asthmaticus. And once we intubated him, I was like, cool, now that he's intubated, how are we going to give him nebs? None of the ventilators have the attachment to do inline nebulizers. So I called the ICU. They literally had to scramble to find one attachment that works on only one ventilator. So it's, you get by, but there's going to come a point where like this one piece that we find for this one patient is not going to be available for the next patient.
So, I mean, that's why they have all this resistant bacteria, because these tubes, which are plastic tubes, they have been used and reused over and over again for a year and a half. It is something that's disposable here in the United States. And these are plastic. They are not available because they are not allowed.
Mhm.
And not even, what is the dual use? What is the excuse not to allow plastic tubes for ventilators? Israel, United States, are you listening, please? This is a plastic tube for the ventilator for a nebulizer that can never be used in any weapon, can never be a threat to the biggest army in the Middle East and to the empire of the United States that has all the nuclear weapons, all the power in the world, are threatened by a piece of plastic tube for ventilators. If Trump and his administration and American politicians and the Israelis, who are the biggest democracy in the world, the most moral army in the world, are depriving 2.3 million people and their doctors, their nurses, from a simple plastic tube for a nebulizer. Imagine if you have a child who had an asthma attack and you don't have this tube, or you have a tube that has been in use for a year and a half, that has all kind of the most
Right.
resistant bacteria in the world, all the world infected with these words. That's why Dr. Razan is saying that the bacteria now there is resistant to everything, because this bacteria is in the tubes and it's passing from one patient to one patient, because they have to extubate the little bit least sick to put the most, the most critical patient. Then they have to switch them back around, seeing the same, using the same tubes, the same germs going all over the place. This is like genocide by infection. I mean, it's a medicide. I don't know how to describe it. It's all the crime in the world
And
together.
yeah.
Yeah.
And there's no sterile technique. So even placing chest tubes, for example, and I really, when we're not rushing at just one patient, I really try to emphasize sterile technique with the doctors and the nurses. But even as much as you emphasize it, there's no drapes, there's no gowns. So as big as you make your field, there's no drapes and there's no gowns. So nothing, at the end of the day, no technique is going to be completely sterile ever. Even something as simple as, which this time it was not an issue the last time I was here, electrolytes. I can't get electrolytes on patients. If I am desperate for electrolytes on the patients, I have to go and tell the lab, I have to get electrolytes on this patient, because they have such limited supply of, I don't know what it is. I don't know anything about the lab, but like what I think is the reagent to run the test. And they have such limited supply on all the hospitals that it will only be run on certain circumstances. ABGs, VBGs, same thing. Sometimes the machine works, sometimes the machine breaks, sometimes they have the available supply, sometimes they don't. So ABGs and electrolytes, which are so basic, which are so essential to patient care, are incredibly limited and reserved for only the most severe cases. And even then, it may not be available. So yesterday I needed an ABG on a patient and I was told, no, we can't run it anymore. It's not available.
Razan, I have a question for you. So just, for us to know, what is the mortality and the morbidity of anyone who comes to these hospitals right now? Like how, compared to your experience in a regular emergency room, like the person who comes, what are the chances that they will actually live?
So if we and let's talk medical patients, not explosive injuries, because the mortality for explosive injuries is quite high, especially if it's, intra-abdominal or intracranial. Their mortality is quite high. But if we talk just medical patients, someone who comes to the hospital, for example, in DKA, right? DKA patient comes to the hospital, even if they're in their 70s or 80s in the United States, there's a good chance that they will leave the hospital. Here, there is a very high likelihood that these patients are going to die. Septic shock. I had a patient a few days ago who came in septic shock, and I, gave her fluids, put her on pressors, started antibiotics. She started to become more responsive. She started to wake up. Her blood pressure was improving. I went to the ICU and found out a few hours later that she died. I personally was shocked, because this exact same patient, had I seen her in the United States, she would have lived. She would have lived. So there are limited pressors, limited antibiotics, limited resources, limited beds, that when a patient comes in and they're in their 60s and they're sick, their mortality and they're sick, whether it's, pulmonary edema or DKA or asthma, COPD, whatever medical condition they may have, if they're sick, there is probably, I would say, a 70 to 80% chance that they will die in the hospital. And even the mentality now is that like someone in their 60s, in their mid 60s is like a very old patient.
Wow.
They're treated as though they are like our geriatric population in their mid 80s because of the lack of medical care, not just in this moment, but throughout the duration of the war. They haven't had access to medications. Sometimes they'll find their medicines and they'll be available. Sometimes they won't be. Sometimes they have access to dialysis. Sometimes they don't. So, and there's no follow-up. There's no, outpatient clinics. So those are the cases that really actually upset me the most when I see these medical cases. And I'm confident that in any other scenario, if I had the same patient in the United States, that patient would not die. Those are the ones that really, really upset me.
So Razan, you are saying that all the experience, all the knowledge, all the experience that you learned as American doctor and a Western medicine doctor is something that you can barely apply. You cannot even apply there because of the lack of the basics of doing anything to help these patients. You don't have the right medications, you don't have the sterile equipment, you don't have the right equipment, you don't have the all the things that we go to school for to learn to protect the patients and try to save them the best way possible. You know them, you are experienced, you're very experienced emergency room doctor, but even with all your knowledge, you are practicing kind of like a blind medicine. It's just, just without access to labs,
It's damage control medicine. It's
Yeah.
damage control, right? Even a patient who comes through the door, I look at this patient and I know immediately this patient needs to be intubated. If the patient gets intubated, it may not happen for another hour and a half. Why? Because we have to think about if this patient's intubated, they think about their prognosis because this patient's going to take a bed in the ICU. There's limited beds in the ICU. If a mass casualty incident comes in an hour or two, and we put this medical patient already with a poor prognosis in the ICU, then we won't have a bed for the MCI patient that comes in. So we'll make decisions to not intubate certain medical cases if they have a poorer prognosis or if they're like older in age, because we're anticipating that we may get a mass casualty and we're going to have to keep that bed for another. I mean, it's the worst decision to ever have to make. And this process of going back and forth and trying to make this decision, because, they've lived it. They've had that situation where they've had to, they had a patient that was intubated and they had nowhere to send them. And the patient stays in the ER for a day or two, but then you don't have beds and then you're taking care of other patients on the floor. So it's a trickle effect. So when they see one patient, they're thinking about the next 20 patients that are going to come in after this patient. So sometimes after an hour of going back and forth and me like trying to push like, no, but this patient really needs to be intubated. This patient really, maybe the patient will get intubated, but now we've waited a whole hour. We waited an hour and a half and I can't blame them. I absolutely cannot. And you start to kind of adapt to that way of thinking. I mean, I've been here long enough now and it's my second time where I now can see a patient, even a trauma patient, that, in the US, if they came into any major trauma center, immediately would be intubated. But you look at this patient and you say no, because you know that even if you intubate them and you do everything for them, that they're going to die. It's just a matter of time. Why take up a bed in the ICU? Why take up a ventilator? So you just make that decision. And sometimes sometimes it's me making that decision. And within 30 minutes to an hour, the patient does die. And you look at them and you start to kind of recognize the severity of the injuries. And, even for example, if it's a bad brain injury, there's no CT scanner here. So we have to transfer them to another hospital to get a CT scan. I know that if I intubate this patient and I send them for CT and I send them back, by the time they come back, they're going to be fixed and dilated. No one's going to take them. There's no neurosurgeon. No one's going to take, they're going to die. So it's a really challenging position that the medical staff are under right now. The decisions that they're having to make are decisions that no doctor anywhere in the world should ever have to make. A patient comes in, trauma patient, ATLS. You start airway, they're not breathing, they're not protecting their airway, no question, you intubate and then you continue. But here you have to practice otherwise.
So you're an
Thank you,
emergency, sorry, Kramat, one last question. You're an emergency room doctor, and we know emergency room doctors are trained to be able to deal with any emergency, any catastrophe, any mass trauma. And you're saying that with all your training, with all your experience in the US, even being in Gaza, nothing that you went to school to prepares you for the magnitude of devastation. I think we lost Razan. Yeah. Okay.
Yeah. Maybe she'll be back.
Yeah. Mariam or Iman, are they?
Hold on. Nidal, I also wanted to ask Razan one
Yeah.
final question.
Mm.
Did you hear Nidal's question, Razan?
It was breaking up. I didn't hear his question.
Yeah, so, Razan, you're an emergency room doctor. You're very experienced. You work in major trauma centers here in the United States. And from what you're describing is nothing you went to school to, nothing you worked with prepares you for the amount of trauma, the magnitude of devastation that is happening in Gaza, especially also compounded by the fact the lack of tools, lack of medication, lack of staff, and all these things.
Mm-hmm.
So do you feel this way?
Is that a question, or do you want me to confirm? Yeah, I mean, this is not trauma, right? Yeah, as an ER doctor, you learn ATLS, you learn how to take care of trauma patients, which normally when you have trauma patients, you have a few, one patient, two patients, even if you have like a major, car crash, you'll have several patients, but you also have several doctors, you have multiple staff members. Here, this is war medicine. I mean, this is not typical medicine that anyone in any traditional medical school or residency program is going to learn at all. Nothing in any training will ever prepare someone to come and practice medicine in Gaza. Nothing.
Razan, one final question for you. And we took so much time from you. I know you have so much to do and it's getting late and you need rest. You have been doing advocacy before you went to Gaza. You are a very active person in terms of advocating for the safety of patients and the safety of the people in Gaza. Do you have a message for the medical community in the United States and in the US that you would like to leave us with before you go back to your work?
It's such a hard question because when you're here and you see all of this and that the world sees it. Everyone knows what's happening. Everyone sees it. It's hard to start to lose faith in humanity and to lose hope. But I think it's still our responsibility to continue to advocate, to continue to speak out, especially from a medical standpoint. There is no question that, the targeting and the bombing of hospitals is unacceptable. There's no question. Nobody can argue that. So we need to continue to remind people of that. We need to continue to advocate for the safety of hospitals, for the safety of medical staff. I mean, the stories that I've heard, and it's so common that I'll be just sitting with a nurse or a doctor and they're like, yeah, I was abducted and I was in prison for 6 months during this time to this time. I mean, the majority of the staff at some point or another have been in an Israeli prison, and they'll share the stories, and then they come right back to work. I mean, they're so dedicated to their work and to serving, their people. We need to highlight these stories and emphasize the fact that these beautiful souls that are here to serve humanity, just like the rest of us who have dedicated ourselves to the field of medicine, we should not be targets. They should not be targets. Hospitals should not be targets. The hospitals are sanctuaries. They are supposed to be safe spaces for people to receive medical care only. That's it. And we just need to keep doing, advocating, sharing, highlighting, emphasizing, and not accepting any excuse. Well, this is happening in the hospital. No, absolutely not. There is no excuse. There's no justification. It does not matter. Hospitals are supposed to be protected spaces. Healthcare workers should be protected. And that's it.